Hello, good evening, Chitara madam. I think she's not joined. Some net issues there. So I welcome her for the first our academic session of Maha IP with Raigad IP. And Journey is the first day of every month we're going to do. But due to logistic and other thing, we start doing today. So friends, I welcome our experts, Dr. Rahul Yadav, neurologist from the Chennai, and Lila Deshpande, well-known development pediatrician from Navi Mumbai. I wrote both speakers, Dr. Priyanka Amankar from MGM, and Dr. Anjali Gokans is our president from Palghar, and our president, new president, I can say Ramakant Patil sir, and as well as immediate IPP, Hemant Gangolia, and continued city all our Dr. Amol as a secretary. So friends, we started this on first on Doctor's Day in year 2021 and continued this journey, and many other academics, I think branches also started this. So I will not take much of time. I invite Ramakant Patil sir to give her his blessings to this our initial to start the journey. Sir.
It gives me immense pleasure to talk on this first academic topic of this year 2023 journal journey, after we had an installation meeting of executive board members on 1st of January at Thane, an excellent hospitality of Thane Mahapedicon team. I have attended many sessions of journal journey in 2022, and what I suggest Chitra Kulkarni madam and the team of journal journey, and there will be another 4 or 5 coordinators from each region, so there will be a good representation of the people who are presenting a journal topic to experts. What I think that there should be some congruent sum up which is usually done after the topic is read. But if the expert tell us about whatever the topic is being selected, or some this thing new topic of journal journey is selected, what is already known, what have this finding has added into that, and how it is going to help. So the take home message for the audience will be very easier in that case. So I think we will make this year this change, and every expert we should let them know what will you like to talk in before the person presents his this thing, whatever journal journey topic is there, whether he or she wants to sum up what is already known and what this today's talk is going to add to the topic. That is one thing. And secondly, adding coordinators from many areas. Otherwise, this has been an excellent activity going on. One of the many 5-6 activities which has many people have thronged on this activity on first of every month. This year, because of this meeting and all the yesterday's very good talk by Dr. S.B. Balasubramaniam, Bala, we had postponed this on 4th. Yeah. So I request Dr. Jay or Dr. Chitra Kulkarni madam to continue the proceedings.
Thank you, Ramakant sir. So I welcome our Hemant sir to give his blessings to this
program. Thank you, Dr. Jay. Yes, already Dr. Jay has said this journal journey, which was started on Doctor's Day of year 2021, and it continued in 2022. And involving the other states too, as Goa, Gujarat, Andhra Pradesh, Telangana state. And on behalf of IIP Raigad as well as Maha IP 2022 team, we really are thankful, and we are thankful to the new team as well as Dr. Ramakant Patil sir to continue this journal journey. Yes, what he said, that was the only concept, because it was a brainchild of mine, Dr. J, and our guide mentor, Dr. Nimen Monti sir. The purpose of this journal journey was that the experts, what is existing, and now with this article, what will it change the practice of ours? That was the aim of this journal journey. Yes, Dr. Ramakant, what his sir has said is absolutely right. So we will just try to do this thing. And Dr. Ramakant sir, this is your team. So here you can make whatever changes you want. It is always welcome changes. So you can make it accordingly. Yes, I welcome our respected dignitaries, Dr. Upendra Kinzaudekar, guest of honor in absentia. He is involved in one of the program. He will definitely join for a few minutes to this program, as well as our experts, Dr. Rahul Yadav sir, Dr. Leena Deshpande Madam, as well as our great speakers, Dr. Anjali Madam, Dr. Priyanka Madam, our excellent moderators, Dr. Chitra Kulkarni, Dr. Jay Bhandarkar, as well as I see our convener, Dr. Milind Bharadia, making the presence here, as well as the editors, Dr. Tripti Madam is there, and my right hand Secretary General, Dr. Amol Pawar is also there, and also Dr. Chitra Kulkarni Madam has just joined. So let us hope for this good session, continuing all, because this was done in hurry, because the team has changed. They have the plans in there, and whatever sir has said, probably from next episode it will be implemented properly. And I just remember his theme, what he stated in his meeting: aspire to inspire. So that will be his theme. Probably it will be revolving all that around. And thank you very much for continuing this journal journey. Thank you, Dr. Jay.
Yeah, and to be very frank, is not hurriedly done. It was a properly planned. Speaker was Mohanty sir decided the topics properly, अच्छी तरह से उसका training, winning, trial, everything अच्छे तरह से करके करे. It's not hurried. To be very honest with you.
Dr. Jay, I didn't mean that. I meant what was the फ्लायर मध्ये काय थोडंसं राहिलं होतं आपलं सर्वसाधी प्रेझेंट जे आपलं हे होतं त्याच्यामध्ये काय आपले नवीन इयरचे थीम आणि ते मेन्शन करायचं राहिलं. दॅट वॉज माय इंटेन्शन, नॉट प्रिपरेशन. येस,
वेलकम डॉक्टर अमोल. थोडी थकल्यासारखे दिसत आहेत, एवढी पळापळ केली वर्षभर तरी त्यांचे ब्लेसिंग्स महत्वाचे आहेत आपल्यासाठी. अमोल प्लीज.
येस सर, थँक्यू जय सर. I was to welcome all the dignitaries and all these things, and already Gangolia sir has done all the things. So welcome both of my president, Dr. Hemant Gangolia sir, Ramakant Patil sir, then senior developmental pediatrician, today's expert Dr. Leena Deshpande ma'am, then senior neonatologist Dr. Rahul Yadav sir from Chennai, then both the presenters, Dr. Anjali Gokan ma'am, she is the executive body member of Maharashtra IIP, as well as she is current president of Palghar IIP also, and Dr. Priyanka ma'am also. I welcome Dr. Neha, Dr. Vikas More sir. He is the president of incoming president of Raigad IIP, Dr. Ajay Kohli, secretary. Then all the EB members present in the meeting, Dr. Milind Bharadia sir, convener, and Abasai Patenkar sir also. Dr. Manjusha Sherkar ma'am is also there, and Dr. Sadachar is also there. So journal journey session, last year we have conducted almost 11 sessions, and without fail they all were on 1st of every month. So it is a very nice initiative by Dr. Jay sir, Dr. Gangolia sir, Dr. Nimen Monti sir, and Chitra Kulkarni madam. They are the backbone of this program. And in as previously discussed, along with Raigad IIP, MAHIP is continuing this very nice initiative this year also. As Dr. Ramakant Patil sir has also suggested to add the coordinator from next month onwards, from next episode onwards, we will be adding them also. So without wasting much time, I request Dr. Jay sir and Dr. Chitra Kulkarni ma'am to proceed further. Thank you.
Yeah, I'm extremely sorry for the problems of internet in our area. And now may I request our enthusiastic coordinator, Dr. Jay Bhandarkar, to introduce our first expert, Dr. Rahul Yadav, an excellent resource of knowledge and experience, and then the introduction of President of Palghar IIP, our speaker, Dr. Anjali Gokarna.
Before Dr.
Can you place the share? Yeah, Dr. Jay.
Before Dr. Jay said, I would like to acknowledge the presence of Dr. Neha Singh, yourself also even. Then I also see Daba Sahib, and then Shulba is there, Madam is there, Milind Bharadia is there, and all these new who have joined. Thank you very much. As well as my IIP Raigad President, Dr. Vikas More. And
thank you, sir. Thank you, sir.
Yes.
So I will very excited to I think give introduction of my own batchmate and friend, Dr. Rahul Yadav. He's a graduation and project from the VM Medical College, Solapur, and DM Neonatologist from the LTM Medical College, Mumbai, working actively more than 25 years in the field of neonatology, and versatile experience of working all type of hospitals, all grades of hospital, I can say, from primary health center to own NICU, आणि सगळे प्रयोग करून मे बी इंटरनॅशनल स्टँडर्डचे पण त्यांनी हॉस्पिटलचं काम करतात सध्या ते. सो ही हॅज work in our government, corporate, trust hospital, individual person, individual hospital. That is the lead consultant neonatology in the Rainbow Children's Hospital, Chennai. And he is yes, out of box thinker for neonatology and for life also, right? तर त्यांच्याकडनं बघून शिकण्यासारखं बरंच आहे. आमचं एखादा तुम्ही गेट टुगेदर अटेंड केलं तर तुम्हाला राहुल यादव काय कळतील. मी फार काय सांगणार नाही त्यांच्याबद्दल आता. सो थँक्स फॉर हिम फॉर दिस जॉईनिंग एज एक्सपर्ट टुडे. फर्स्ट स्पीकर डॉक्टर अंजली मॅडम. त्यांच्याबद्दल सांगायचं म्हणजे खरं तर काय प्रेमळ स्वभाव कसा असावा. खरं तर मी मराठीच बोलतो, पहिला दिवस आपल्या वर्षाचा. तर मायसेल्फ अँड डॉक्टर हेमंत गंगोले वी विजिटेड दॅट ओपन आय थिंक सेरेमनी ऑफ आपण म्हणतो ना आपला पालघरचा IIP-चा. तर त्या पद्धतीनं वेलकम आणि ज्या गोष्टी होत्या त्या ठिकाणी, तर दॅट किक स्टार्ट ऑफ दॅट इयर वॉज फ्रॉम पालघर IIP. अँड आय व्हेरी मच के शुभ सकून म्हणतो ना आपण कुठल्या गोष्टी चालू करायचं. परत याच मॅडम इथं आलेल्या आहेत. तर म्हणजे की हे वर्ष पण रमाकांत सरांचं IIP-चं चांगलंच जाणार आहे, म्हणजे आय डोंट हॅव एनी डाऊट. So she has done graduation progression from the JJ Group Hospitals, diploma from College of Physician and Surgeon, trained in the emergency neonatology and pediatric echography, diploma in pediatric development pediatrician, contributed articles on subacute cystosarcosis in Indian pediatrics, and she's practicing as a consultant pediatrician neonatologist since 1980 at Vasai. And she was the head of the neonatology DM Petit Municipal Hospital, current president of Palghar district, and as well as she's the EB executive body, a member of Maharashtra IIP at present, and past secretary of Indian Academic Association. And I can say very knowledgeable, very enthusiastic. When I post my exercise video on the Facebook or WhatsApp, immediate madam चा मला पण लगेच येतो की मी पण असा एक्सरसाइज करते. So welcome madam, and you can share your screen and start your presentation. Thank you.
Thank you so much, Jai, for that very enthusiastic and lovely introduction. And very good evening to Dr. Ramakant Patil, our present Maha IIP president, Dr. Hemant Gongolia, immediate past president, all the EB members, the experts for today, all members of the Raigad IIP. Thank you for giving me this opportunity. And today I am talking on
Any issues?
yeah, no, I have to share screen and present now.
Yes.
Yeah. Yes.
Yeah. Can you see my presentation? Okay. So
Yes,
I have given this opportunity to present on severe anemia at birth, its incidence and implications. The discussion today will be from this article in Journal of Pediatrics, which was published in September 2022. And the authors of which were Dr. Timothy Barr et al. And the impact factor of the journal is very important because it's the relative importance of the journal within its field, and it measures the frequency with which articles from that journal have been cited. So in the year 2021-2022, impact factor of Journal of Pediatrics is 7.14, maximum being 10, 7.1 is considered an excellent score. The researchers for this topic were from the Obstetric and Neonatal Operations Department of Neonatology at Intermountain Healthcare, which includes 18 hospitals under its purview at Utah in USA. What is the background for this study? Why did this group of researchers think that studying severe anemia at birth was important? They had studied anemia at birth and like several others, but most of these neonates whom they had worked up did not need any treatment or did not need much workup. And severe anemia was not defined or studied. So they thought there was a need to create a nomogram for less than the first percentile to define severe anemia, see how often it was diagnosed at birth, and also the cause for this. So how did they describe their objective? First, was to identify neonates with severe anemia within the first 6 hours of birth, determine whether the healthcare workers recognize such anemia at birth, and the probable causes and outcomes of this anemia. The study design was a retrospective cohort analysis in 10 years from 1st of January 2011 to 31st of December 2020. What was the method? So initially, 350,000 newborns were evaluated in the 18 hospitals of Intermountain, and a nomogram was created of hemoglobin hematocrit versus gestational age for the first percentile value of hemoglobin. This is, as you can see, this is the first percentile. This is never actually plotted. What we normally have in all nomograms are the 5th percentile, the median, and the 95th percentile. But these group of researchers felt that the 5th percentile does not give us a really good indication of the severity. So they created first a nomogram of the first interval. So over the 10 years period, there were almost 3 lakh newborns, and only 76,000 of them had a CBC test performed within the first 6 hours of birth. Out of these 76,000, only 355 had a hemoglobin falling below the first percentile. From these 355, 11 of them had to be excluded as they had a faulty collection. Of the 344 children who were evaluated by the researchers, they used an algorithm to diagnose the cause of anemia. This is the algorithm they created to divide the patients as per their cause into hemorrhagic, hemolytic, and hypoproduction. If these tests or these events in antenatal period or postnatal period came positive, or these tests came positive, or any of these factors were there, then they were classified as hemorrhage, hemolysis, and hypoproduction. This algorithm is not present anywhere, and the research team has created it. Also, they were then classified as mild, moderate, and severe. The mild ones had a hemoglobin which fell 1 gram less than the first percentile. The moderate had a hemoglobin falling between 1 and 2 grams less than the first percentile, and severe had 2 grams less than the first percentile. They also saw how many doctors recognized severe anemia on the first day that CBC was done. This they saw from the records that were available. And also, the third thing they did was, as per gestation, the weight, and that algorithm, they made a diagnosis. So what were the results of this? Of the 3 lakh neonates which were included and 76,000 blood samples that were drawn, 344, that is the 0.1% of that, were found to be severely anemic. 191, that is only 55% of children were recognized as anemic by the healthcare team, whereas 44% of neonates were not recognized in spite of having severe anemia. 35 neonates of these 344 children with severe anemia died before discharge. So 10% of them died. This chart, they have shown us that which were the patients who they recognized the anemia on the first day. They were smaller in gestation. They were smaller in birth weight. They also had an initial hemoglobin which was less. And also the cause most probably was hemorrhage. This was compared to those who were not recognized. Those who were not recognized were a little older and of more birth weight. They also saw what were the factors that were present in the children who died prior to discharge. Of the 35 or 36 children who died, they were all of lesser gestation than those who survived. They were of lesser weight than those who survived. The hemoglobin was much lower than those who survived. And also hemorrhage still factored as the most important cause. What were the causes of severe anemia at birth? There were two ways. One was what the doctors, healthcare workers recorded as the cause. And then there were causes which were recorded by the research team as per their algorithm. And they found that only hemorrhage was still the highest number. Hemolysis only was 30 amongst the 90. Mix of hemolysis and this were the next most common, and hypoproduction were following the last. But a large number of them, they had no diagnosis. They classified the severe anemia further into mild, moderate, and severe. So this was the one which was following less than 1 gram of the first percentile, 1 to 2 grams of the less than first percentile. And this was falling less than 2 grams of the first percentile. In all of these three, mild, moderate, and severe, you can see that hemorrhage was the commonest cause. Hemolysis was the second commonest cause. Hyporegenerative or hypoproduction was the third, and mixed formed a larger group. And here you can see that still unable to determine were very large in number. Of course, those who had severe hemorrhage, they could still come to a diagnosis, but those who had a mild, less than just 1 gram, large number of them could not be classified as any anemia. So we saw that unable to determine probable cause was 168, whereas those who had hemorrhage were 97. Those who had hemolysis was 41, and those who had hypoproduction were 1. Those who had mixed hemolysis, hypoproduction, hemorrhage and hypoproduction, and hemorrhage and hemolysis. So hemorrhage and hemolysis comes as the largest cause. And there was one child who had hemorrhage, hypoproduction, as well as hemolysis. What were the possible causes of hemorrhage? Fetal bleeding like abruptio placenta or other perinatal events, feto-maternal transfusion, twin-twin transfusion, fetal internal bleeding not subgaleal like intraventricular hemorrhage or liver hemorrhage or adrenal hemorrhage, subgaleal hemorrhage, and other causes of hemorrhage. There was hemolysis, immune like Rhd factor, Rhc and other factors, immune, other immune factors, non-immune like DIC, non-immune of other hypoproduction like Diamond-Blackfan and other syndromes, non-syndromic. Amongst the non-immune hemolysis, they also found an occasional case of hereditary spherocytis, alpha-thal, pyropoikilocytosis, and dyserythropoietic anemia. These were very uncommon, but still present. In the discussion, they said that conventionally we describe anemia as a hemoglobin value below the 5th percentile. Here, however, they found that none of these neonates who were less than the 5th percentile were symptomatic and they didn't need much workup or treatment. So they decided to define severe anemia, like I said earlier, and they created their own nomogram. They were surprised when they wanted to know whether healthcare workers did recognize that 45% of, that means almost half the children were not recognized as anemic by the healthcare workers. And they felt that if they had a nomogram chart where if they had plotted the hemoglobin at birth according to the gestation, it would have helped them recognize all these patients. Those who were recognized as anemic at birth had very low values of hemoglobin. So amongst those 50%, 2 grams less than the first percentile, and most of them were hemorrhagic anemia. What was their conclusion? They concluded that severe anemia at birth often went unrecognized on the first day of life. Using an algorithm for diagnosis helps classify severe anemia at birth. An earlier recognition and more accurate diagnosis of anemia at birth can be made using the nomogram. What is the new knowledge we get from this study? That a hemoglobin hematocrit gestational age nomogram, can help us to identify severe anemia at birth and take appropriate measures. Also, creating an algorithm to classify this severe anemia can help us to identify the cause of anemia. What is the strength of this study? They studied a large number of neonates, almost 3 lakhs, and their CBCs at birth. They created a first percentile reference interval for recognizing the severe anemia, and they created an algorithm to help classify and identify the cause of severe anemia at birth. However, this study does not specify whether the neonates were admitted in NICU. It also does not reveal why CBC was done only in some of the neonates in the first 6 hours of birth. The study has not considered the impact of changed policies of delayed cord clamping, milking of cord, and drawing umbilical cord samples, which were introducing in the past few years. So what we can do is we can create our own nomogram considering our population. We can create an algorithm, and we can study the effects of changed anemia preventing practices on hemoglobin in neonates. In India, we can also study the effect of maternal iron on neonatal hemoglobin. With that, I thank the experts today. I thank Maha-IP and Raigad IP.
Thank you.
Madam.
Dr. Rahul? Can we get your expert comments, Dr. Rahul Yadav?
Yeah. First of all, I thank you very much to give me an opportunity to speak in this August gathering. The audience, usually the general presentation is there. We actually classify the audience to 3 types of audience. One is a student type, where they want to know the concepts and p-value and retrospective cohort study and these details of statistical concepts. Second type of audience is actually our audience. Most of us are practitioners. So we want to use the knowledge to improve our outcomes tomorrow, right from tomorrow. When you go for call or LACS or normal delivery, or a baby lands into a hospital, this particular study, how it will add to our improvement in our outcome. And third type of audience is academicians, intellectuals, where they want to know the truth. So this particular truth-seeking behavior, passing behavior, and improvement in outcome behavior, these are not exclusive to each other. All 3 are present in all of us. So let us focus on only one aspect of it. Can we see that, put up that objective slide again? Objective slide was the 3rd slide. So that at the end of the presentation, we'll come back to the objective and whether the objectives have been achieved or not, and what are the strengths and deficiencies in that. Because these objectives, sometimes we lose the focus of objectives. So if you are able to put the objective slide, it will be quite easy to discuss. The 3rd slide. Next one. Next one. Next one. Next one. Next one. Yeah. So this one is, first of all, there are 2 objectives in general. First of all, identification of certain baby having severe anemia, and second is identification of the cause. Identification and recognition of anemia and identification of the cause. Enough. So if you see this one, in spite of all this extensive work, this study acknowledges that half of us cannot actually recognize that baby is anemic. So why we actually miss this anemia at birth? And second is, in spite of all the algorithms, almost 50% of cases, we are unable to diagnose the cause. So what do you think is the reason for not recognizing, and even if you recognize, not finding out the cause?
This question is to me?
Yeah.
Okay, so in this paper itself, the researcher said that since the most important cause was hemorrhage, perhaps they were missing the feto-maternal hemorrhages, which were, the commonest cause, as they were not doing the KB test in mothers. Also, they thought that including the flow cytometry to recognize the antiglobin F would have helped them to know feto-maternal transmission. So that was the reason they felt.
So this particular dilemma actually we went through a few years back. We actually tried KB test and we actually searched for literature about it, and we found out KB test is not useful in diagnosing fetal anemia at all.
Okay.
Because KB test was done, was repeated in some cases, even KB values were increasing, and those babies are not anemic, and those who are anemic were not having KB test positive. So KB test is no longer actually test to diagnose fetal anemia. KB test is then what causes this anemia? Then we understood that there is a small subset, or if you see 10% of deliveries, almost here also, if you see out of this one studies, 10% of babies are having severe anemia. And this 10% rule also applies to rules about those babies who are having partial cord compression. The umbilical cord has got umbilical vein and umbilical artery. The umbilical artery is thick walled, umbilical vein is thin walled. In case of partial cord compression, vein gets compressed, artery doesn't get compressed. Now what is happening is baby is losing blood to placenta, but placenta is not allowing blood to come to the baby. So now this particular situation leads to partial cord compression, one of the commonest cause of anemia, which cannot be diagnosed by this algorithm at all. But it can be diagnosed by only detailed history taking. History taking in the sense, here we get typical history of oligohydramnios or polyhydramnios. We get history of very small cord, history of leaking of liquor followed by fetal distress. So these are the babies who are born anemic, and hemoglobin initially can be normal. If you see carefully, many times we are not able, even if you do hemoglobin, some anemias can be missed. Because in anemia, if you do hemoglobin early, hemoglobin is going to be normal. Later on, water comes into vessel and then dilution of the anemia develops. So doing hemoglobin also we can miss. So what we can do next time when you go for a call or any baby comes up or something, first of all, we look usually at color of the baby. Color pale. That pallor usually actually raises our suspicion about anemia. But this pallor is usually transient. It is heavily dependent on temperature. This pale baby is become pink very soon. But if the baby is acidotic, this vasodilation can falsely become pink, but actually baby is pink. Even to only hemoglobin can be normal. So there is a combination of investigation, history, and examination. All three, if you put, then we are able to diagnose this anemia. Now, as far as history is concerned, typical history in these babies will be a gush of liquor. When polyhydramnios or oligohydramnios, gush of liquor, after liquor came down, started to come out, fetal distress because of partial cord compression. Here is the baby where we get gush of liquor followed by fetal distress, followed by reduced fetal movements, and baby's pain, plus hemoglobin may or may not be normal, may or may not be low. These are the typical triangle of clinical feature, investigation, and history will pick up more and more anemia. Second question comes up is, what is the gain if you diagnose anemia at birth? So what we are going to add up to that particular baby's outcome. So naturally, when anemia is diagnosed early, we tend to give PRBC early, transfusion early, shock, hypotension, acidosis, renal failure, HI. All these outcomes can be actually improved if we treat anemia at right time. Second corollary to this, right now there is at present trend of delayed cord clamping. The delayed cord clamping is supposedly trying to improve shock, acidosis, and neonates and infants also. But the problem is the last studies are not actually supporting this routine use of delayed cord clamping in all babies, especially preterm babies, because some cases are there where delayed cord clamping actually has caused more damage than polycythemia, jaundice, increased risk of IVH, and all those things. So this particular study raises the possibility of selected use of delayed cord clamping in those cases where anemia at birth is expected. So in those cases where abruption of placenta, twin-to-twin transfusion, cord compression, in those cases actually we can use the delayed cord clamping effectively without causing side effects. So it is a very excellent study, especially the figure 1 what you showed, figure 1. Can you show me the figure 1 again? The first figure where the normogram is there, the first percentile. The first percentile is very novel concept because we have been obsessed with only percentile so far. But this figure is our eye-opener that this first percentile is something which is actually clinically relevant, because less than fifth percentile can be statistically relevant, but first percentile can be clinically relevant, because here diagnose the problem, we are going to treat it, PRBC. So we should not over-treat it. So this first percenter concept can be a game changer for not only this particular hemoglobin, but for many parameters in future. So thank you very much for presenting this, which we can actually, we can put this figure in all our NASU to see the percentile of hemoglobin, depending on gestation, rather than all other. Thank you very much.
Thank you. And also the researchers felt that this nomogram should be shared with the lab personnel, because the lab should then report immediately if they find that it is below the first percentile on the nomogram.
Yes, absolutely.
Yeah.
Other.
Is cod milking also equally harmful, or is there any other benefit or problem with cod milking versus delayed cord clamping?
Yeah. So it has been studied also in detail about those who require really the delayed cord clamping or cord milking, or those babies who are potentially hypovolemic or anemic at birth. Means those babies who are already having cord compression with along with aspects. These are precisely the babies, unfortunately, who require restation quickly. Problem is, when the baby's aspects are able to cut the cord and take to the restation table. Right present, we can't restate the baby in front of the mother. So this particular dilemma of cord milking versus delayed cord clamping at present is being applied for all babies. And that's why the results are actually mixed. If we apply these results, this one, to select cases of those babies who are at risk of hypovolemia and anemia, then I think that can be the next
outcome can change
of research.
Thank you.
Thank you very much, Dr.
Thank you. Yeah, thank you. Yeah, it was a lively discussion and we really appreciate it. We are interested in basic research which targets the common pediatric problem and results which we can apply from tomorrow. So our next topic is about common problems of feeding. And to introduce our expert, Dr. Leena Deshpande, and then speaker, Dr. Priyanka Amonkar, may I request our newly appointed Raigad IIP Secretary, Dr. Ajay Koli. Ajay, are you there?
Yes, yes, ma'am. Good evening. Am I audible, ma'am? Okay. Thank you. Thank you, Chitra ma'am. I'm Dr. Ajay Koli. Welcome all. Sorry for joining in late. Now our next expert on the next topic, feeding problems, is Dr. Leena Deshpande. Everybody knows her. She is a very well-known developmental pediatrician in Navi Mumbai. A brief introduction. After her MD pediatrics, Madam trained and worked in UK for 10 years in neurodevelopmental pediatrics. She is a founder of ICAN, Child Developmental Center, Kharghar, Navi Mumbai, visiting consultant in developmental pediatrics and Apollo Hospital and MGM Hospital, Navi Mumbai. Joint National Coordinator for Taught Neurodevelopmental Disorders, West Zone Convener for Taught Autism and Poor Scholastic Performances, member of IIP Task Force for IIP National Consensus Guidelines on ADHD, Autism, Newborn Hearing Screen, Learning Disability, member Accreditation Committee for Institutes applying for IIP Fellowship Program in Neurodevelopmental Pediatrics, academic editor of IIP Handbook of Developmental and Behavioral Pediatrics, and faculty on various other forums. With this, I welcome Leena Madam to the session.
Thank you.
Over to you, ma'am. Yeah,
Speaker.
and our speaker for today's session is Dr. Priya Amonkar. She's Madam is MD in Fellowship in Pediatric Critical Care. Madam is Assistant Professor in Department of Pediatrics, MGM Medical College, Navi Mumbai. Presently affiliated as a pediatric intensivist in Apollo Hospital, CBD, Belapur. And Madam has 5 international publications and 4 national publications to her name. So with this, I welcome Dr. Priya Madam to the session, and I urge her to begin her presentation. Thank you.
Thank you very much, Ajay sir, for your warm welcome. I would like to thank everyone for giving me this opportunity to speak today. I'll be sharing my screen now.
Yeah.
Okay, is my screen visible?
It's visible, ma'am. You can go ahead.
Okay.
Madam, 1 minute, Dr. Priyanka.
Yes.
Our CIP President, Dr. Upendra, joined for his busy schedule. Sir, tumche blessings, patkan.
Oh, thank you so much, Dr. Jay. At the outset, I express my apologies for being delayed here because, as you know, we had a nationwide launch of PG Reach program, IIP's comprehensive PG training program, and which will be running for 5 days. So I'm sorry because we just finished that inauguration over there. So again, my apologies. Jay had extended his invitation for the same. At the same time, I'm very happy to be here. And this is a great program which is running for last 2 years. Jay is at the helm of affairs, and I'm sure this is going to continue even in 23 with more strength and vigor. And someone like Priyanka, Dr. Leena, Dr. Chitra Kulkarni, I'm sure with Dr. Vikas and Ajay Kohli at the helm of affairs in IIP Raigad, this is going to reach newer heights, definitely. I'm sure Anjali is also there as a part of this today's program. So great beginning in 2023, and I wish this program a great success. Thank you. Thank you so much.
Thank you, Upendra sir, for joining this and giving blessings. I think we should continue this. Dr. Priyanka, over to you again. Thank you.
Welcome, Upendra sir.
Yeah. Thank you. Thank you.
So today my topic is going to be feeding problems as an indicator of developmental delay in early childhood. So just some time back, we were discussing with Leena madam how the load of developmental delay is increasing day by day, and there are lesser number of developmental pediatricians. So with this in mind, this particular paper is looking at how we can recognize developmental delay early. So as sir was saying, I'm going to be looking at this paper from a researcher's point of view, where I will be looking at what are the flaws in the design, what are the strengths of this paper, and whether the take-home messages which they're giving, can we actually take them? Are there any, is there something missing, or is there something more that we should be looking at? So feeding is a complex activity which involves coordination of multiple systems like oromotor, neurologic, cognitive, GI. Their feeding problems are classified as organic or non-organic. They may include limited appetite, selective intake, fear of feeding. So why are we looking at feeding problems as an indicator of developmental delay? Because these are generally major parental concerns. Parents may not recognize that their child is having a developmental delay, or they may not report these problems to the pediatrician, but feeding problems are definitely brought to the notice of pediatricians by parents. So these problems may actually be an indicator of another problem, which may be in one of these other systems. So what is known through previous studies is that feeding problems are quite common. They're common in normal children as well as children with severe disabilities. Very few population-based studies are there to evaluate association between these two. And most studies which have been done in picky eating only. So there are studies which have shown that persistent feeding problems are indicative of adaptive and social behavioral delay. There is another study which shows that persistent feeding problems are predictive of pervasive developmental delay at 7 years. And very few studies are showing link between early feeding problems and developmental disabilities. So the aim of this study was to determine whether feeding problems are indicators of developmental delay. They did this through two objectives. First was they checked the association between frequency of feeding problems and developmental delay using a questionnaire, which is ages and stages questionnaire, which is administered to the mothers. The second objective was to investigate association between feeding problems at 30 months and developmental status, which was assessed using a developmental scale at 4 years. Their hypothesis was that there would be an association between these two, and this association would grow stronger as the child grows up, and it would probably be, there would be a stronger association if a child had persistent feeding problems at 3 time points. Rationale for selection of time points, so that time points which are selected were 18 to 3 time points between 18 and 30 months. The rationale was that generally solid food eating habits of children are established by 2nd and 3rd years of life. So methods, this was a prospective longitudinal cohort study. The population which they took for this particular study actually belonged to the Upstate Kids study. So this study was originally designed to evaluate the impact of infertility treatment on child health. So here I would like to bring out a flaw in the design, that this they basically included mothers who belong to this particular study, and they enrolled them when the child became 4 months old. So the original cohort consisted of 4,824 mothers with 5,841 children who were conceived with infertility treatment. And it also included 2,074 twins, along with some others also. So from this study, 5,034 mothers and 6,171 children were recruited into the study when the children were 4 months old. So over here, I would say that the sample was basically non-random because it included a lot of children who were born out of infertility treatment. It included a lot of twins. So infants conceived by infertility treatment were oversampled. Possibly there can be over-reporting of symptoms, and there was oversampling of twins. So twins are basically, this is a confounding factor because they are at an increased risk of developmental delay as well as feeding difficulties. Although the original study found no association between infertility treatment and developmental delay, however, I would like to point out that there is a flaw in designing this particular study. So the procedures was that mothers were asked about feeding problems and developmental delay in their children using ages and stages questionnaire at 18 months, 24 months, and 30 months. After this, out of this total 6,000 children, a subset of children, they did developmental assessment using the Battle Developmental Inventory at 4 years of age. Inclusion criteria were children whose feeding behaviors and developmental delay data was recorded at least at one time point between 18 to 30 months. So 2,338 singleton and 1,259 multiple delivery were included. The subgroup who underwent developmental assessment, this is a formal assessment. So in the first part, they took history from the mother using the ages and stages questionnaire. In the second subgroup, they actually performed a developmental assessment using the BDI-2 at 4 years. So the subgroup, how they selected was, they selected all children who had a probable developmental delay on ASQ at 30 to 36 months or on MCHAT, which is the modified checklist for autism and toddlers. Apart from this, they included all twins and higher order multiples, and they also included a random selection of singletons who passed both ASQ and MCHAT. The feeding problems which they studied were mealtime distress, food refusal, and mechanical issues. They collected data at 18 months, 24 months, and 30 months. They calculated average scores as well as categorical scores. So for basically grading the severity of feeding problems, they divided the feeding problems under two categories. In the first part, they asked the mothers how often their child engaged in behaviors which indicated feeding problems. So the scoring was 0 if never, 1 if the mother said rarely, 2 was sometimes, and 3 was often. So items were averaged to form scales indicating severity range 0 to 3. And 90th percent cutoff was different at different age groups. So if the score was 1.66 at 18 months, 1.64 at 24 months, or 1.75 at 30 months, the child was rated as more than 90th, above 90th percentile. So additional items, because feeding problems can be different at different ages, additional items were asked at 24 and 30 months. So here they asked the mothers how often they were having, and they found out children who were above 90th percentile. In the second part, they tried to find who were the children who were having persistent problems. That is, at all the 3 times mothers reported that they still had some problem with feeding. So here the scoring was 0 was never, 1 was if there was a problem at one time point. Score 2 was given if the mothers reported at 1 to 2 time points there was a delay, and 3 was given when at all the 3 time points the mothers reported that the child had some feeding problems. So persistently high number of feeding problems were defined as more than 90th percentile. So this particular feeding scale was later validated in healthy and undernourished children 16 to 24 months old after certain revision. So in this particular study, it was not validated. So how did they record data related to developmental delay? They used the ages and stages questionnaire, which contains 5 domains: fine motor, gross motor, communication, personal social functioning, and problem solving. Here the scoring is dependent upon that particular milestone. If the mother says yes, the child has achieved, then it is 10. If the mother says this child does this particular activity but only sometimes, then it is 5. And if the mother says no, the child is not able to do it, then the scoring is 0. So in each domain, delay is defined as a score less than 2 standard deviations. So here also we have subgroup domain-wise scores, and we have a total ASQ score. They also found out because a lot of children were conceived through infertility treatment and there were many multiple births, twins. So they had a registry for congenital malformations as well. And in this particular study, 244 children had 1 or more malformations, which can actually be explained by multiple and higher number of multiple deliveries. So moving on to the results over here. So the first part. Okay. So on the feeding problem scale, so here they asked about how often is your child having feeding problems at 18 months, at 24 months, and 30 months. So here all scores range between 1 and 2. That is, mother reported having faced the problems never or sometimes. Then on the persistent feeding problems, 21% children experienced high feeding problems. That is more than 90th percentile at 1 or 2 time points. And only 2% experienced feeding problems at all 3 time points. So looking at the other data here, you can see that gestational age of the children who were included was on an average of 37, but it ranged from 23 to 42. So many preterms were also included in this study. In order to look at other confounding factors which may lead to feeding problems, they looked at sleep problems. So 11% children had sleep problems. They looked at history of GERD, 17% had. Now here another thing, we can see how 37%, which is a huge population. So 37% of the children included were born out of infertility treatment, and 35% were showing plurality. That is, they were either twins or born out of higher order births. Now, when they compared total score of feeding problem scale with developmental delay, so in unadjusted models, there was a significant feeding problem by age interaction. That is why they analyzed it at 3 different time points. So what they found was, in stratified analysis, that feeding problems were associated with an increased risk of total ASQ delay and delay in all domains at all ages. When they adjusted this for multiple factors related to the mother and the child, they found that a 1 point increase in feeding problem score were more than twice likely to have a delay at 24 months and 4-fold likely to have a delay at 30 months. So 1 point rise in the ASQ score at 30 months this child was becoming more than 4-fold likely to have a delay. Now, adjusted analysis of persistent feeding problems. So in the previous slide, we saw they analyzed the total score. And here they're looking at children who persistently had feeding problems. So children who experienced high feeding problems at 1 or 2 time points were more than 2 times likely to have an ASQ score delay compared to those who never experienced high feeding problems. And children who faced high feeding problems at all 3 time points were more than 4 times likely to have an ASQ delay. Now, looking at the subset of population in which the formal developmental assessment was done, here they found that a 1 point increase in feeding problems was associated with a scoring of 4 to 6 points lower on the BDI-2 total and subscales. So if you adjusted it for other maternal and child factors, it came to a reduction in BDI to 3 to 4 points. So as I was discussing that there were a lot of confounding factors, after removal of 244 children with congenital malformations, 1,259 twins and higher order multiples, 887 preterms, that is excluding total of 3,649 children, adjusted findings were consistent to previous table. Food refusal, mechanical distress, behavior subscales were similarly associated with developmental delay. That is, there was no clear pattern that one particular type of feeding problem was associated with delay. Here again, I would like to point out that out of 6,000 children, approximately that they included, they had to exclude 3,600 children to find out the real findings. So here they could have actually marked this as an exclusion criteria and done the study in the other children who were not born out of, who were not twins, who were not preterm, or who did not have any congenital malformations. So what this study adds, association between feeding problems and developmental delay were not limited to any particular developmental domain. There was somewhat weaker association between feeding problems and developmental delay at 18 months age group compared to 30 months. So this, they believe that this weaker association may be because as the children grow older, they outgrow their feeding problems and they'll learn behaviors which then help them feed better. But if a child has persistent feeding problems at 30 months also, this child is particularly more likely to have a developmental delay as well. So no particular feeding problem was strongly associated with any developmental delay, and delay was similar across food refusal and mechanical distress subscales. Strengths of this study studied a wide range of feeding problems as compared to other studies which focused on picky eating only. The cohort was large, although I will disagree to this particular large cohort part because majority of that cohort consisted of confounding factors. Another advantage was that they measured at 3 time points, at 18, 24, and 30 months. They included developmental assessment as well, and they did not only rely on the maternal history. Limitations of the study cohort was actually originally designed with a different aim in mind. That is, they wanted to study children who are born out of infertility treatment. More than half of the cohort consisted of twins, higher order birth, preterm, and those with congenital malformation. Validation of feeding problem scale was done later after revision. Data related, another thing that I would like to point out is that they did not collect data related to early feeding habits. So they did not ask whether the child had any issues in breastfeeding, during initiation of complementary feeding. So if they would have recorded this, probably we could have seen whether there's an association, and we can actually look at earlier intervention as well. So both feeding problems and delays were derived from maternal reports based on the ASQ, and only a subset of children were subjected to formal developmental assessment. This particular subset also was not random. They had certain inclusion criteria. Another limitation was that the sample in this study was largely European American and well-educated. So we do not know whether we can apply this to our Indian scenario. Overall, the generalizability of the study is unclear, and there is possibility of confounding due to unmeasured variables. Conclusion, frequent feeding problems, especially those that persist into 3rd year, could be used to identify children at risk for developmental delay for more targeted screening. So the study was conducted in USA, New York. So AAP recommends that developmental screening should be done at 9, 18, and 30 months. However, they have found that less than 37% of pediatricians actually screen all children less than 3 years of age. IAP also recommends screening using standard tools at 9, 18, 24, and 36 months. However, if the American data is showing only 37%, I wonder whether in India it is even up to that much. So why the study was done is basically feeding problems are easy to identify, and they may be a symptom of underlying developmental issue. So screening children whose mothers raise concerns about feeding behaviors could help us identify children at risk of developmental delay. And more weightage should be given to feeding problems that persist into the 3rd year. So further scope is we need to establish generalizability by eliminating sampling error and confounding factors in the study. And similar studies need to be conducted in Indian population. In India, generally, we are using the Denver Developmental Screening Test for comparison. And we may need to, if we had to do a similar study in India, probably we'll have to develop a revised feeding problem scale where we include Indian cultural and food habits as well. Okay.
Thank you.
Thank you.
Yeah, thank you, Priyanka. Excellent and elaborative paper you have presented, and that has triggered a lot of discussion. I'm happy for that. Over to Dr. Leena for her expert comments.
Right. Good evening, all. Thank you very much first, Maha IAP and Raigad IAP for this invitation. Dr. Priyanka, it was a very, very well presented, very, very well, you evaluated the entire methodology, the limitations, and excellently done. And as rightly you said, I'm going to put my video off because my Wi-Fi is a bit unstable. Yeah. So, as we've rightly said, when we are looking at articles, there are various facets to it. Certainly, we look at purpose, the methods, the data, the results, the discussion. But finally, what is very important clinically is what is the take-home message? Can we actually do any changes in our daily practice from tomorrow? Now, when I look at any article, the first thing that we look at is the title of the article. The title of the article is very important because that makes us decide if we want to read this article further or not. So if you look at this title, The title is Feeding Problems as an Indicator of Developmental Delay in Early Childhood. So this is a very good title. Is it relevant to us? Of course it is. Because we know that feeding problems are associated with developmental problems, and so are sleep issues and other behavioral concerns, etc. We know this already. What I would be interested in when I'm reading this article is how early in childhood are they talking about? Because in developmental problems, timing is everything. So as you mentioned very rightly, as you go through the article, the introduction is very well written, and we know the association between feeding problems and developmental disabilities. And the fact that feeding a child is a lot more. It also includes the temperament of the child, the parental expectations, their understanding of feeding matters, their understanding or perception of what is over or under feeding. So if we take a simple, our usual Prader-Willi syndrome, after the initial poor feeding in infancy, the child starts eating excessively and putting on weight. And a parent might quite be happy about this child's feeding. So it's not very straightforward because every family dynamics are different. So we need to keep all those things in mind when we talk about feeding difficulties in children. When we go to the methodology, you said very, very rightly, they've taken the 3-point feeding issues. They have done the developmental assessment at 4 years. And they have taken off later on the congenital malformations, the premature prem babies, the multiple pregnancies, all of which are at higher risk for developmental and feeding issues. So basically what they are saying is the non-high risk kids, in the non-high risk kids, they found that feeding problems at 30 months is associated with somewhat lower developmental scores at 4 years developmental assessment. So that is their conclusion. Now, what I'm not sure about the methodology is, what did they do with the kids who had screening test positive at 18 and 24 months? Were they referred? Did they have early intervention? Did they have developmental assessments at that time? And what was the result? I don't think they mentioned that in the article.
Not really mentioned.
Correct. Second thing, as you said very rightly, the study group is from families undergoing infertility treatment. So apart from the other confounding factors, there's a lot of stress, there's a lot of anxiety, and then maybe subsequent joy and maybe inadequacy feeling. And whether this will affect bonding, feeding, etc. in the first year of life, we don't know. So again, there's a lot of confounding factors there. The sample taken is the well-educated American, so again, can't be generalized as you said. Both the feeding questionnaire as well as the ASQ is a parent report. Both these questionnaires are reported by parents. So obviously the association is going to be inflated because the same parent is reporting on the similar kind of questions. Now, the other thing which you talked about, the cohort, I agree, because in the end, what they've said is only around 28% agreed for developmental assessment. Out of those, I think 3,500 3,600 children which were initially recruited, only 516 had developmental assessment at 4 years. So why did the rest? Probably there were no concerns. The final figures are not very big, especially for a symptom which is so common. So I'm not very happy with those numbers at all, as you rightly mentioned in your talk. Now, I'm just trying to summarize the whole thing, and what they've mentioned in discussion, as you said, that they've explored this feeding because they thought it might be easier to identify early. But they're starting at 18 months. 18 months is not early from the point of view of feeding. So you quite rightly said they have not looked at the infancy or early infancy feeding patterns. They've also mentioned in that discussion, because I read this paper in the evening, they did this study, they've said, because they believe that feeding, not because they believe that feeding problems can cause delays. This is their statement. But what do we think? Do feeding problems, can it cause a bit of delay? Because in clinic, what do we see? We see that fussy eaters are being fed with distractions, mainly a mobile or something, to finish off the eating. This will lead to screen habit, which causes problems with lack of stimulation, which can lead to further communication delays and problems with behavior. We know that first, the mother, a fussy eater, the mother is trying to finish off feeding. So independent eating will not develop because the child is not given an opportunity to eat, because the mother is so focused on just putting something in the child's mouth. We also know that in these fussy eaters, parents are so focused on making the child eat something that maybe noodles, biscuits, junk food, or even just drinking milk, large quantities. And all this will affect the nutrition quality. Iron deficiencies, other deficiencies will affect behavior and development. So it is possible. I'm wondering whether it can explain their so-called somewhat lower developmental scores at 4 years, feeding affecting development to some extent. The other point, they said that they feel that feeding problem, as you mentioned, are a symptom of developmental problem. Then isn't it better to focus on overall development and developmental surveillance? Because as we said, most kids will be picked up. Isn't it better to focus on improving our rates of developmental surveillance and screening rather than chasing the boat at 2.5 and 3 years of age? They mentioned that, as you said, very less number of pediatricians in the US screen, but that's the whole reason that they have brought out a need for developmental screening and early intervention in the infancy and the first 18 months. In the end, they propose that to screen this, as we said, the toddlers with feeding problems more at 30 months. But isn't that too late? Are we not missing those 1,000 days of the first 1,000 days of neuroplasticity, which we talk so often in our talks? So I think take-home message, if I want to look at the whole article, with all due respect, I think the authors are mainly epidemiologists, statisticians, and researchers. And they may have got some numbers out, but their conclusion line, where you have mentioned in the conclusion, the feeding, where children with feeding problems in the 3rd year are at the greatest risk and should have developmental screening. This is like looking at the whole thing upside down, completely ulta. We've already lost our 1,000 days of early intervention, which will help improve our developmental trajectory. So in conclusion, is this original article, is this work novel or mainly confirmatory? Definitely not novel, and certainly not impressed. I am. Can we improve our clinical practice based on this article? Certainly we can. Because we realize once again the importance of regular developmental surveillance and screening, along with the anticipatory guidance of feeding and other areas affecting development, like screen time and sleep. So certainly there is certainly this article has opened our eyes to the fact that we do need the developmental surveillance, and we do need to improve our developmental surveillance and screening program. Thank you.
Yeah, ma'am, and do this oromotor coordination and speech delays related to the feeding problems, where we screen that way, or the parents, they complain about speech delay, then we ask about feeding, and then we get the delay in development?
Certainly, I think a lot of feeding problems can be because of oromotor or orosensory problems. Okay, so when we talk about orosensory problems, the child might be having oversensitive to the various senses in the oral cavity, or maybe undersensitive. A child who's oversensitive will not accept a lot of foods or feeds. A child who is undersensitive will try to grab on anything that he can get. So he will be chewing his pencil, he will be chewing, he'll have pica-like symptoms. So certainly when we are talking about feeding difficulties in children, we look at all these aspects. Whether one, it is behavioral, second, it is sensory, third, it is neurological, fourth, is it the parent or is it the child? So there are lots of things. So feeding difficulties in children, very, very common. And we need to go through all these aspects before we come to a conclusion. And you're rightly said, these are the muscles, the oral muscles which we use for chewing are the same ones which we use for talking. So a lot of children might have what we call as apraxia of childhood, where the coordination of the muscles of the words are there in the brain. But when they are trying to come out outside, the coordination of the oral muscles is not very good. So they are not able to say the word. So that is called apraxia of childhood. So yes, the communication issues can be very commonly associated with feeding issues, with oromotor issues as well.
Thank you. Thank you, ma'am. Then over to Jay. Are there any question answers in chat box you want to ask, Dr. Jay?
And as well, also anyone who is present in the attendees, they can ask directly the questions if they have.
Yeah, can I ask?
Yeah.
Yeah, I wanted to know, so very often we have children with asphyxia who have a lot of feeding difficulties on discharge. So are these the patients whom we can think of, future having developmental delay?
No, absolutely. I mean, children who have asphyxia are already high risk children, and they should have a regular developmental surveillance and developmental screening program. So they should have the high risk follow-up, and they will already be included in the developmental surveillance program. Yes.
So I thought it is quite irrelevant to think of feeding difficulties at 18 months and 3 years.
Absolutely. I mean, I looked at the title and I thought early development, early childhood means probably, less than 6 months. But then they're talking about 18 months and 2.5 and 3 years of age. I think you miss the boat of trying to diagnose or catch a developmental delay early.
So they have
so the take-home message is that we have to intervene early.
Absolutely.
As
Pick
a
up early and
clinician,
intervene early.
As a clinician, the topic is interesting. It does interest it. Tells us that we should look at feeding problems and take a clue.
Correct.
But as a researcher, that particular article does not really hold any ground. It was some other study. Out of that, they extrapolated this data and published something.
No, as I said, I think the authors are statisticians, so they have managed to get out some numbers,
some results,
which
yeah.
look very impressive. But I'm not sure about the clinically, whether that's going to be relevant in our country.
Yeah.
Ramakant sir, your comments.
9 months is we have already missed the bus when we say we are going to diagnose at 9, 18 or like that. So it is earlier the better. That is what is more important, as elucidated by Leena madam wonderfully. So what I want to ask Deshpande madam is that how early we can say, or which feeding difficulty definitely tells us this is likely to have developmental delay, or we need to intervene early. Which are the feeding difficulties which clinician or pediatrician generalist should address to?
No, I think that when we talk about feeding problems, there is a whole umbrella of disorders. So just somebody might be just a fussy eater, but I think extreme irritability while feeding. Throwing the child, when the child is being fed something, the child throwing the head back means that the child is having problems somewhere in the oral cavity, somewhere there, which is not allowing the child to be comfortable when the child is feeding. With that, if there's a high risk neonate, then obviously we know that earlier in the first 6 months, we'll come to know that there is some concern about the development as well, apart from the feeding. So in child whom we are worried about, we should be looking at all aspects. So as we said, it's not just feeding, it is also sleep problems, feeding problems, extreme irritability, hyperactivity. All those are all very related to development. So any symptom you find, you look at the whole picture and not just at one part of the child.
So it should be other way around, that many times there is a high risk history is there.
Yes.
You will be looking for the feeding difficulty. Many times parents may come only with the history of feeding difficulty. It is a clinician's job to elucidate, fish out the history and all the risk factors, and then probably it will help us.
Absolutely.
There is a question in the chat box whether we should tell parents due to feeding, so child has a feeding difficulty, whether you should disclose to the parents, there may have some developmental problem to your child. Whether you should disclose to the guide to the parents about
So
that.
I think this is very useful, because a parent who's already stressed goes under a lot of stress when you try to give labels to the child. So I think when we start doing developmental surveillance and developmental screening, so for example, in this ASQ screening test itself, there are questions which tell the parent what the child should be doing at this particular age, and what kind of activities the parent can do with the child if the child is not doing that particular thing. And if so, when we apply a screening test, say at 9 months or 12 months of age, and the parent is, we are able to start this dialogue of development with the parent, rather than saying, so we don't have to put a label to the child that this has a problem, but we can say that the child is not yet doing this. Why don't you do these particular activities as mentioned? And then we meet again in a month's time, and then take it forward. And then in a month's time, if the child is still not, please do refer for further assessment or early intervention.
Okay, I have one question.
Yeah.
When you talk about the whether it's feeding difficulty itself, a child may have the developmental problem. Whether feeding difficulty with the weight loss or child is not gaining weight is more relevant than only feeding difficulty.
Most certainly. I mean, when you have weight loss or something like that, it is significant. It's a feeding disorder. Okay, so a fussy eater might be because of the child's temperament, or the mother is, mother's over expectation, she's overfeeding or whatever else. But when you have actual weight loss, then obviously it's a very significant feeding disorder and needs to be treated as such. Looking at the cause, whether it's neurological or anything else.
Right. Well answered.
Yeah, Dr. Jay, anything from YouTube? Any questions, Pallavi? Now we are in concluding phase of this very informative and learning experience for all of us. And may I request Raigad IIP Secretary, Dr. Ajay Kori, to give vote of thanks.
Thank you. Thank you, Chitra ma'am. Yeah, with this we come to the end. It was really an informative session. I am sure now we all will approach the feeding problems and the related issues with a whole new approach. I wish to thank all the dignitaries present, Dr. Ramakant sir, Dr. Gangulia sir, Dr. Pawar sir, Dr. Upendra Kinjwadekar sir, Dr. Mohanty sir, Dr. Bhandarkar sir, our new president, Dr. Vikas More sir, and last but not the least, I would like to thank Dr. Chitra madam who has been tirelessly coordinating and making this wonderful academic journey possible for the past many months now. With this, I conclude this session, wishing you all a very happy and prosperous new year. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Thank you. Thank you.